Hi, everyone. We will get started in just a moment. Thank you for joining. All right, I think we have a good amount of folks who've joined, so thank you so much for joining today's webinar. We will be focusing today on advocacy for health departments and methods, tools, and strategies for mapping out policy landscapes. Today's presentations are being recorded and will be made available via the RAISE and NASTAD websites. Feel free to use the chat or Q&A to add your questions or comments at any time. We'll have time for discussion after the presentations. Today's webinar is a part of a continuing collaboration between the RAISE Hub at University of Washington and NASTAD. Our collaboration focuses on strengthening implementation science through state and local EHE health departments. We encourage health departments interested in learning how IS can support their EHE work to reach out to the RAISE team. There's a consultation form and an email address, which I'll be putting in the chat momentarily. You can also learn more about our collaboration at our respective websites, and I will also put those links in the chat. All right, today's webinar is a part of a monthly webinar series, so stay tuned for more information on our next webinar. So getting into today's presentations, our first presenter today is Jeff Lane, who's an associate professor in global health at the University of Washington and also co-director of the International Training and Education Center for Health. We also have Molly Firth, who's a clinical assistant professor for health systems and population health at the University of Washington and is also principal at MCG Consulting. And we have Thaddeus Pham, who's a viral hepatitis prevention coordinator in the Harm Reduction Services branch at the Hawaii State Department of Health. So thank you all so much for joining. I'm going to pass it to our presenters now to start us off.
Thank you, Krupa. All right, well, thank you everyone for joining today. I'm excited to be here. A little bit just about my background. My training is in law and public health, and I work in both the U.S. setting on health policy research, practice evaluation, and also internationally. I also have experience working at the state health department level. I worked as the legislative affairs and communications manager for the Idaho Division of Public Health for about a year and a half in the 2022-2023 timeline. So I have some experience working on policy research and legislative affairs at different levels, and really looking forward to having a conversation today with you all around the work that you're doing in this space and how we can use all this phenomenal data that your programs are gathering to really tell the story about the good work that's happening and identify some opportunities for improvement. And so I'm going to start off here with just some kind of level setting, sort of an intro to policy, and walk through this and then talk a little bit about some methods that you might use for policy mapping and policy evaluation approaches. So this slide here is showing this traditional policy process cycle. There's many different versions of this, but the idea is that if you try to distill down what is a really complex and oftentimes chaotic process in the real world, you can oftentimes kind of distill it down to these 5 stages. So the first stage is stakeholders or interest holders identify some sort of a public health problem. So this could be government officials. This could be someone in a state or county health department. It could be a member of a community. It could be a frontline implementer. Really anyone who's interacting with the public health system could identify this public health problem. There's then this shift into thinking about, well, what could the government potentially do to address that problem? And this is phase 2, where we start thinking about really specific interventions. You then kind of move through a process of prioritizing those different interventions to a point where the government adopts some particular approach. And so that can happen in different ways depending on the setting, but it could be the governor signing an executive order. It could be a statute passing at the state or federal level. There's many different sort of adoption processes that could happen there. But at some point, the government adopts it and you move into policy implementation. This implementation stage is super important, and there can actually be quite a bit of variation and adaptation that occurs at the policy implementation phase. But the important thing here is that we keep in mind that the policy that's adopted, that's signed in phase three, can oftentimes look quite different during the implementation phase. That could be a good thing, or it could undermine the success of the policy. But we want to kind of think about that as its own step in the process. And then lastly, there is an evaluation of the policy. And oftentimes this is just done ad hoc. It can just be a perception of whether or not the policy is successful. But sometimes it can also be a really rigorous and policy evaluation using kind of traditional research methods. And so we're going to talk a little bit about some of those more formal evaluations here in a bit. Next slide, Molly. So this is just a high level overview of kind of the policy hierarchy to think about. So in the states and then at the federal level, you basically have kind of two variations of this hierarchy, where the most important policy document is going to be the Constitution. We have state level constitutions in the US, and then we have the federal Constitution. Below that, our legislature adopts statutes. So this has to pass through both houses of the state or federal legislature and then be signed by the executive. Under that, then regulations are adopted by the administrative agencies, and those have to align with the statutes and also the Constitution that came before it. And so oftentimes this can be an area of litigation, whereas whether or not those regulations are consistent with those statutes. You can then have strategic plans, which are these medium-term, typically 3 to 5 year planning tools that governmental entities can develop. And then you have these guidelines, which are sort of at the lowest level, which are the kind of standard operating procedures and tools for frontline implementers. Next slide, please. And so as most of you already know, it's important to think about all of these different types of policies happening at the different jurisdiction levels. So, we have the federal level where there's a constitution, statutes, regulations, and so on. All of these also happen at the state level, and I imagine many of you are interacting with that policy process at the state level. But for many important aspects of public policy, there's really important decisions that are made at the county level or even the city level. And if you're thinking about advocacy or doing policy evaluations, you want to think about these various levels and the pros and cons of engaging at these different levels, because it's sometimes, depending on the context, you may find that you can make more progress at a more local level. In other instances, actually, you might find that you're going to potentially have more success going to the federal level. And so that just varies based on the context, but you want to think about what level is the right level that you want to be focusing on for your work. Next slide, please. And so when we're thinking about all these different types of policies that we might want to evaluate or think about trying to look at using the data that is developed through public health programs, I would encourage you to think about a wide range of different types of policies. And so there are a few different levers that come up quite a bit in the public health space. So one that we oftentimes think about is government develops policies to implement public health and healthcare programs. So really that's that design process for direct service delivery. This could be delivering vaccines, it could be delivering educational programs, but that sort of direct service delivery program implementation type lever. Governments also adopt a lot of regulations of private activities. So this is where the government is maybe establishing conditions or restrictions on things like health worker licenses or hospital licenses, and this can be another way to try to affect public health by establishing these rules for private entities. Governments also adopt tax incentives and disincentives. So these are things like tobacco taxes, sugar taxes in some settings, and they can also be used for incentives. So giving tax credits for to help with procuring health insurance. So it can be either used as an incentive or disincentive. Another big category of policy levers is around public health insurance benefits and rules. So whether or not Medicare or Medicaid covers certain services, it could be a requirement that private health insurance covers certain services like preventative services or certain screening services. And then lastly, the criminalization law. So things like laws around substance use, laws around can be as simple as speeding laws, seatbelt laws. There can be a wide range of different criminalization laws, and those can also be looked at from a policy evaluation lens. Next slide, please. And so shifting a little bit, that was kind of our policy 101. So apologies for the folks who've been doing this work for a while, but it's always nice to kind of level set around some of these things before we jump into the details here. But this is just an overview of three main types of policy evaluations. And so you can kind of break them up into content evaluations, implementation evaluations, and then impact evaluations. And oftentimes you're combining these three different methods into one evaluation. And that's actually, I think, a really smart way to approach this is really thinking about a mixed methods approach. But at a high level, a content evaluation is when you are looking at the written policy and you are just comparing that to some set of standards. You can either be looking at it compared to some set of maybe international recommendations or recommendations that came out from some sort of an authoritative source. You could be comparing different jurisdictions to see how my county or state compares to other states in my region, or maybe states that are performing well on a certain outcome that you're interested in. But you're just comparing basically the words on the page to other words on other pages. It is purely a content evaluation. For implementation, we're looking at, well, how well was the policy implemented? This is something where we want to really pull in qualitative data and quantitative data to get a really good sense of the sense of implementation across geographic settings with different subgroup populations, and really requires a good understanding of what data is out there and the strengths and weaknesses of those data. And then impact evaluation is where we're looking at the effect of the policy on health outcomes. This can be structured in different ways. It is typically the hardest to do, but it is possible, especially if you plan ahead and you think about having those routine data systems in place that will allow you to identify changes and outcomes following the adoption or changes to key policies. And so having those really sensitive routine data systems are really important for these impact evaluations as part of this work. Next slide, please. So now I'm going to talk about one particular approach for this that's referred to as legal epidemiology, but really you can kind of think of this as policy evaluation. So this is a process where you systematically collect laws from multiple jurisdictions. And again, this could be states, counties, countries, cities. So you can kind of pick that level. You then look at the laws that exist in those different jurisdictions and can either look at them cross-sectionally. So as of a certain date, January 1st, 2026, or you can do it longitudinally. So you can look over a 5-year period, for example, and see how those laws change during that period of time. You then try to identify these potentially meaningful differences in those laws, and you develop a coding framework to then facilitate that comparison. And typically, this is asking a series of really specific questions that you try to get to the point of having a binary yes no answer to that. And then when you get down to that really nuanced level, it gives you some opportunities to really compare the potential effects of different aspects of the law or policy on different health outcomes or service delivery indicators. Next slide, please. So when you get that really nuanced legal epidemiology or policy monitoring data, you can then overlay that with implementation or health outcomes data. And the really interesting part of this is it then facilitates identifying these natural experiments or these sort of quasi-experimental analyses that you can then use to conduct a policy evaluation. But the key thing here is really having those routine data systems because typically you don't know exactly when a policy is going to be adopted that you may really want to evaluate. And so to get that pre and post data, you're typically going to be using routine data systems. We don't do randomized controlled trials for policy evaluations. We need to monitor it kind of over time. But there are some ways to influence some of the rollout to try to help with identifying it and sort of building some of those quasi-experimental methods. And this is, I think, something that this group is really well positioned to help with because understanding the strengths and the weaknesses of those data and then really helping people identify where those data sources are is really, really important because it can be really complex to try to measure the effects of some of these policy changes. And so understanding those data that you're going to be using to measure the potential outcomes is really important. Next slide. So I'm just going to talk through a few examples of projects that I've worked on around this to show you how you could apply this, a few examples of that. If you go to the next slide, Molly. So this one is looking at an evaluation we did of COVID-19 social distancing policies. So we used a really in-depth coding framework to look at the intensity of social distancing laws at the state level for the first 100 days of the pandemic. And so these visualizations here are just showing some of those results, and they just show how you can convert what is multiple pages of narrative in a law into this sort of quantitative coding data to then facilitate some of these evaluations. So these show kind of the intensity level. So in the upper left and then lower right, the intensity level that these different domains had. So these were movie theaters, indoor gyms, restaurants. So we could kind of show the peak intensity. And then because we did it longitudinally, so we gave a score for every day during that period of time, you can actually show how it changed and so how it ramped up very quickly and then kind of slowly went through this reopening process and how some of those outcomes changed. Some of the intensity differed by the jurisdiction. And so we actually looked at this for a set of US states, and then we also included some other countries. And it was very interesting to see both the variation across state responses in the US and then how that compared to some other countries around the world. Next slide, please. So now these figures are showing how you can then overlay the policy coding data with some health outcomes data. So this was showing the rolling 7-day incidence of COVID-19 during the first 100 days. And you can just kind of see how by overlaying that longitudinal coding data with the outcomes data, you can actually then use this to run different types of analyses, but also just do some basic descriptive statistics to understand how the policy may be interacting with some sort of an outcome variable. Next slide. So next, I'm going to just show some findings from a scope of practice analysis that we did, looking at scope of practice for a wide range of different health worker cadres, looking at the provision of heart disease services. Next slide. So here you can see how we developed a coding framework, which I'm not presenting here, but these are just some of the main findings that ask, could different cadres provide some of these really key heart disease services in the US. And so we looked at it in a little over a dozen different states, and we actually looked at it in the VA and the Indian Health Service as well. And so you can lay out here each one of these bars is a different cadre, and you can see the percentage of jurisdictions that either allow them to do it or not. So this is one way that you can show findings from legal epidemiology. Next slide. Here's another very pretty graphic that I'm not responsible for developing, but it's extremely well done. And our research scientists did a great job putting this together. But this just shows you how you can other ways to graphically display some of these findings. So you're basically taking a spreadsheet and kind of wrapping it around. But it's a nice way to show some of the variation that you can find through some of these laws at the state level. And some of this can be very useful for policymakers because they oftentimes want to know what some of those peer states, so some of the states that they're really kind of maybe interested in learning from, what they're doing around a particular policy area. And this can be a great way to convey what multiple states are doing at the same time in sort of a streamlined graphic. Next slide. So here's another evaluation that we're just now wrapping up that may be a little bit more relevant for this group. And we looked at pharmacist scope of practice laws and whether they allow those pharmacists to prescribe HIV PrEP. Next slide. So this is the high level findings from our policy coding data. So these present whether or not a pharmacist was allowed to prescribe PrEP in one of these states. It shows both some timelines here, as well as some sort of some binary answers in terms of whether or not a training was required in order for them to have that prescribing authority, whether or not health insurance was required to reimburse them for those services. And we had a whole series of questions that we walked through. And you end up with a spreadsheet like this that, again, it can kind of give you a snapshot of the policy environment in multiple different jurisdictions. And then we have a whole other spreadsheet that basically has a response for each of these for every month during a 5-year period. Next slide. And so what we then did was we combined the policy coding data with pharmacy insurance claims data. So here, this just shows kind of at a high level the number of pharmacists that had prescribed at least one PrEP prescription in these states during this period of time. And so the shading here shows when a law that explicitly allowed pharmacists to prescribe PrEP went into effect. And then we could see to what extent adoption increased after that law went into effect, recognizing that in just about every state, pharmacists could previously do this through a collaborative practice agreement model. And so we were really focusing on whether or not these laws that specifically allowed for specifically referenced PrEP made a difference in pharmacist prescribing. And based on our findings here, generally speaking, we did not see a big increase or really much increase at all after the adoption of these statutes. We did this for a 4-year period. I think monitoring is still important going forward, but these are some of our findings from this study, and this is going to be going in for publication hopefully very soon. Next slide. So now I'm just going to give some tips for policy evaluations. I'm going to go through this quickly. So Molly, you gotta keep clicking through this one. You can just keep clicking to the end if you want. Go up to 5. So number 1, define your evaluation questions carefully and make sure they're relevant to policymakers and affected communities. The worst thing that can happen here is when you do an evaluation and then you take it to a policymaker and they say, well, I really wish that you would have designed it some way to answer this other question that we're really interested in. So co-creating those research questions with policymakers and affected communities is really important for having a nice feedback cycle so that the information is actionable by those key actors. Second, I really encourage you to use multiple types of data. Qualitative and quantitative data is really important. Those big routine data systems are really important, but they miss a lot of the on-the-ground context. And so Combining that with interview data is really, really important. Next, take the time to understand the strengths and weaknesses of those routine data systems. Like I said, you all probably know that better than most folks about where the gaps are in some of those systems. And so that's one of the reasons that we want to use multiple different types of data streams, qualitative and quantitative, because there's always weaknesses in each of those. And so really being thoughtful and critical about that is important. Evaluate implementation before you try to evaluate outcomes. Oftentimes, when you start to look at implementation, you see a lot of variation, maybe some suboptimal implementation, and that is a huge confounder for the effectiveness of policies. You can also sometimes find places that are implemented really well and others that aren't, and it can actually set up a nice comparison group for you. So this implementation sort of fidelity and success is a really important part of determining before you moved into looking at outcomes. Compare outcomes with other states to give context. This can be a nice way for policymakers to understand some of the environment in other settings. Next slide. So collaborate with others to design and conduct your evaluation. This can be universities, it could be community groups. I really think that a collaborative process around this really helps improve the outcome and the uptake of the information. Be prepared for the possibility of negative findings. This is something that I think can be challenging, whereby we evaluate a program, we really want it to be successful, we potentially invested a lot of time and resources into it, but sometimes the data just doesn't show that it's having much of an effect. And that doesn't mean that it's not working, but we do need to be prepared for that, that this is one of the reasons that we do the evaluation, and maybe it's going to lead to a shift in strategy. And so being thoughtful about that and ready for that is important. Include costing analyses whenever possible to show that return on investment, or sometimes it's called value for money. Policymakers are very motivated by this, and so having that costing data as part of it is important. I think really making this policy and program evaluation routine helps just streamline all of these steps that we've talked through. If you are just doing this, once every 3 or 4 years, it can be quite difficult. But if you just routinize this into practice, it gets a lot easier. And then finally, communicate your findings in a way that policymakers can easily understand and apply them. It's great to publish them in peer-reviewed journals, but that is something that policymakers are sort of a type of writing and a level of detail that policymakers, generally speaking, aren't that interested in. But there's more effective ways to simplify and communicate to them in a way that they can really run with that information and hopefully make a positive difference in public health policies. And so with that, I'm going to hand it over to Molly, and she's going to tell you exactly how you can do that.
That was a perfect segue. Thank you, Jeff. So I'm going to talk about policy communications, because once you have all this great data, that's fantastic, but you have to be able to effectively communicate it. And that's not something that everyone just naturally is able to do. And it doesn't happen without planning. So this was something that one of our colleagues has said repeatedly, and he's totally correct, because communication is not about what we say or write. It's about what the listener hears or the reader reads. You can have the greatest idea ever, the greatest amount of information about your program ever, but if you cannot convey it clearly to your audience, then you have more work to do. So I'm going to talk more about persuasive communication. I'm going to provide some overall tips and then talk more specifically about tips for written and oral communications. So it can be useful to start with definitions. So persuasion is trying to get someone to do something or change their mind. Advocacy is the process of supporting a cause or a proposal. When you are advocating, you are trying to persuade someone to do something or change their mind. This is why it is crucial to understand persuasive communication if you are going to advocate for your programs or for your work. So as I said, persuasion doesn't just happen. It is a painstaking process. It requires some insight, some planning, and some compromise. And spending the time to do it right will actually save time later. So the first thing that is important is to establish credibility. So this is important because people want to know if they can trust your perspectives and opinions. And credibility grows out of two sources. You can be considered credible because of your expertise. You can also be considered credible because of your relationships. People are considered to have a high level of expertise if they have a history of sound judgment or having proven themselves knowledgeable and well-informed about their proposals. Framing common ground. Even if your credibility is high, your position must still appeal strongly to the people that you are trying to persuade. And at the heart of framing is having a solid understanding of your audience. So understanding that and thinking about that is going to be really important when you think about communicating with different audiences. Provide evidence. The most effective persuaders will use language in a particular way. So they will supplement that numerical data, all the types of data that Jeff just shared, with examples, with stories, with metaphors, and with analogies to really bring these things to life, bring the data to life. That's really going to be what's going to be the most compelling for a lot of decision makers. And finally, connecting emotionally is very important. If you scratch below the surface of decision making, you usually find emotions, some values sprinkled in. And being aware of that and thinking about that as you're thinking about how to present information and how to share information and how to convey it is going to be really important because that will help to make sure that it's resonating with your audience. Okay, so as I said, framing is important. The messages that you use for your audience and how you frame them are just really important to nail down in advance. Public health messaging has evolved substantially over time. And we often, as public health professionals, want to use certain words and language that reflect what our values are. And you should also be mindful of your audience. What I can say to a conservative legislator in my state may be very different than what you can say to a conservative legislator in another state. Sometimes we have to use language that will resonate with our audience. And one example of this is when I was working to extend Medicaid postpartum coverage, we often used gender-neutral language and referenced birthing individuals in our materials and in our messaging. But we also talked about moms because we knew that that language would actually resonate more with all of the legislators that we were talking with. We didn't like having to do that, but we knew that that was going to be an important step to getting people to agree with what we were trying to do. I want to also mention here that having multiple voices singing from the same song sheet is always better. That way, policymakers hear consistent messaging from different and multiple voices. So that's also an important piece that I think Thaddeus will get to again later. You all have loads of data about your programs and the impacts they have. Facts are so important, but they are not going to be able to do the job on their own. So again, thinking about how you use examples, stories, analogies to bring that data to life is very important to think about. And at the end of the day, you have a message and you have to have an audience for that message, but no audience is ever going to care as much as you do about your message. This is a harsh but accurate reality that came to me from one of my communications colleagues, and it's one that I always try to keep in mind. So when we think about policy communications, we like to focus on both written and oral communications. So I'm going to break these down a little bit more. When we think about written communications, that would be policy briefs, letters, op-eds. And when we think about oral communications, that could be just presenting in meetings, it could be testimonies, and it could be more formal, large presentations. So when you write a policy brief, you want to think about writing something that is for the general public. Not every policymaker is going to be an expert on your body of work. Frankly, most probably aren't. Policymakers have a lot going on, and this requires policy briefs to be thoughtfully constructed to break through the noise and have the desired impact. They're busy, they have a lot going on. You want to create something that will get in their brains and make a difference. So how do you do that? The first thing that I want you to think about is honestly using ChatGPT or some other AI tool to come up with a catchy title to grab the reader's attention. I don't like AI. I try not to use it, but this is the one thing that I tell my students all to use it for. I think that AI can come up with really great presentation titles and policy brief titles and even op-ed titles, and you should definitely be using it for that. I also like to see 3 key points at the top of a policy brief so that I know what to expect when I start reading it. I want to know if I want to keep reading or not. And that's going to help anybody who has a short amount of time to be able to focus on something to really keep their attention. Keeping a policy brief short is also going to be effective for policymakers. Their eyes will start glazed over if there are too many words. So using a QR code to link to more information is a great way to make sure that they have what they need in a digestible format, but can also find more information if they need it. The next one here is references. Please include references. They really help to build credibility and just are too important to leave off. And then consider how you lay out your policy brief. So think about using subheadings and data callouts to help the reader follow along and also just keep them engaged. To that point, photos and images can be great. Again, they're useful for breaking up text, which will cause people to get lost in the details. Charts and maps can be very helpful, and there are templates out there that can help you to format something that looks nice if you don't have that support within your organization. Never underestimate the value of a strong op-ed. Op-eds have long been relied on as a way to communicate broadly with the general public. This is a huge audience, and it can really help to influence conversation. And policymakers also see these opinions because they pay attention to them. So an op-ed can influence public policy in 2 different ways. Indirectly, by getting this issue out into the ether, but then directly by also reaching policymakers or other decision makers. An op-ed will provide a strong opinion on a clear single issue. They should be timely and relevant. This diagram is a useful way to think about how you frame out an op-ed. You have an engaging first sentence to grab the reader's attention, an opening paragraph to state your primary focus, short paragraphs that are incredibly focused, a closing paragraph that reiterates the main point and includes a call to action, and then some memorable final sentence to stick in your reader's mind. Because ultimately, you want them to understand an issue and feel compelled to take action on it. Maybe it isn't appropriate for you to write an op-ed, but you could absolutely contribute ideas, data, and information to an op-ed that is ultimately going to be authored by someone else. Okay, so I'm going to go through some important writing reminders quickly, but hope that they will stick with you. Again, policymakers have a lot of topics and issues to learn about. They have 15-minute meetings on a variety of topics throughout the day with different constituents, different advocacy groups. They cannot and will not read everything on a topic, and they are highly unlikely to read any journal articles. So you got to think about how you're going to grab their attention. First thing, academic writing only persuades academics. Policy communications requires a different kind of writing, and the next 2 slides will provide some great tips on how to avoid that academic writing. So first, simple words, clear and succinct sentences, and organized paragraphs go a long way. Try not to use acronyms. This is so hard in public health and healthcare because we love us some acronyms. But unless the legislator or policymaker that you are talking to is a public health or healthcare professional, you should not assume that they will track these acronyms. And the number 8 is on this slide because when writing for the general public, you should really be writing at an 8th grade level because that's what the US adult reading level is. So this is important to keep in mind. We are all used to writing for experts, other experts, and we have been rewarded for using big words with those experts. The general public does not want your big words or your complex sentences. And then writing for impact is different than writing for a scientific journal. So the inverted pyramid is important to consider when you're organizing your writing. I love this visual because it helps you see how different it is from academic writing. Instead of spending a ton of time on the background and the supporting details, you start with the bottom line and then you tell them why it matters before you get into the supporting details. And that's just a universal thing with all of this communications, is just thinking about that bottom line up front. I wanted to provide a case study to just bring these points to life, and I'll try to do it quickly. I'm on the Washington State Maternal Mortality Review Panel. This panel is required to submit a report to the legislature every 3 years. This has been around in our state since 2016, and I've been on the panel for 6 years, and I've reviewed all of the reports over time. I've even used the reports, some of the recommendations in my advocacy work. Over time, the reports have gotten longer and longer, and they've had more and more recommendations because we can constantly think about things that we should be doing better to help folks in this very vulnerable period. Our 2017 report had 20 recommendations. 2019 report had 51 recommendations. And then we really doubled down in 2023 with 115 recommendations. And I was getting feedback from my advocacy peers that they were overwhelmed by the number of recommendations and that it was not helpful for legislators, because where should they even start with this many recommendations? So over the course of the last year, I engaged in multiple conversations with our staff working on our maternal mortality review panel about how to make a different 2025 report to be more readable and actionable. Some of the things we did were remove some metrics that were causing a lot of confusion. For example, using data related to pregnancy-associated deaths, which really was not the main point. Those are just folks who happened to be pregnant when they died. They could have died from an accident, car accident. Their pregnancy had no bearing on their death. That's not what the main point was. We wanted to focus on pregnancy-related deaths. So we had to take out that data completely because it just wasn't germane to the main point that we wanted people to take. Separating out legislative recommendations from more detailed recommendations were just a way to really focus the legislators on what was important for them to think about. And finally, we incorporated stories from people about their own pregnancy or postpartum experiences. And they were experiences about homelessness, racism, miscarriage, preeclampsia, and perinatal mental health. And the stories really helped to bring the report to life and make it less about the numbers and more about the real impacts and the real humans that are impacted. So that was really helpful for us to see come out, and my colleagues were thrilled to see a very different type of maternal mortality review report. So the other thing is oral presentations. I'm just going to hit a few tips. First and foremost, when giving any type of presentation, please make eye contact with your audience. It helps you to build some rapport with them, and it keeps them engaged with your presentation. And then practice. Practicing what you say will help you to feel more comfortable with the words and to avoid stumbling over any words that seemed great when you wrote them, but didn't actually come out of your mouth appropriately when you went to say them. I feel like the more comfortable we get in our jobs and careers, the more likely we are to think that we don't need to practice because we're experts in our topics, but we all need to practice. We can all benefit from it. And if you are using slides to support your materials, please avoid complete sentences. Use visuals. You don't want people just sitting there and reading your slides. You want them engaging and thinking through what you're saying. Finally, legislative testimony is important to consider. Some of you may be in a situation someday where you are asked to testify in front of a legislative body. You also may be in situations where you are asked to help prep somebody else who will be doing that. So the first thing to know, time limits are real. Testimony should be prepared with different versions. A 60 version and a 2-minute version should suffice. Some committee chairs will just very politely ask you to wrap up if you are exceeding a time limit. Others will literally cut you off mid-sentence. And it is good to be prepared for either scenario to make sure you're comfortable with a game time pivot. Next, do not drown decision makers with statistics. They can really only hold maybe one statistic in their head. You might get a couple that can hold a little bit more, but not too many. and then use social math because a number may be completely meaningless to someone unless you can connect it with something that will resonate with them. So I've long used social math to talk about, how many people are on a program is equivalent to the number of people who can fill Lumen Field or some sort of sports stadium that I know that legislator will understand and resonate with because they can visually see that, even if they can't do that without an actual number coming into their brain. So finally, working with policymakers, trust is a really necessary part of the work. As I mentioned, building credibility is really important. It makes you a trusted resource. Relationships are critical. You can't be the only person advocating for your program. Having other people to support your messages is incredibly useful. Policymakers are people too. They have taken on this really challenging role, and bless them for doing it. I would not do it. But at the end of the day, they are all humans who are trying to do the right thing given the complexities they're contending with. And finally, good champions can be cultivated over time. So I'm going to stop sharing and I'm going to pivot, I think, to Thaddeus to talk a little bit more about how he has done some of this stuff.
Awesome. Thanks, Molly. And I love that you ended with time because I think time is an important component in the advocacy work that we're all doing, or policy work, actually. So I just want to make sure, can folks see my screen? I'll make it bigger for you folks. Da, 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 da. Yes?
Yes, we can see your slides.
Perfect.
Good.
Okay, so thanks everyone. Thaddeus Pham, he, him. I'm the Viral Hepatitis Prevention Coordinator in the Hawaii Department of Health. People in the community know me as the Queen of Hepatitis. I do respond to Your Majesty, Your Highness as well. But what we'll be talking about today is an example of how we enacted change in Hawaii to sustain viral hepatitis programming. So, both of the speakers before me, Molly and Jeff, mentioned the importance of relational work and relationship. So I always start kind of with who we are. So I am part of the health department, but I also work with our coalition, Hep Free Hawaii, which has been around as long as I've been in this position. So since 2011, it's multiple stakeholders and constituents over the entire state, as well as national and global partners. Which is very important because there's literally only two of us doing dedicated hepatitis work in the Department of Health. That's me, hello, Queen of Hepatitis, and Miriam Sabui, who is our epidemiologist that we just hired literally 2 years ago, right? So a very, very, very tiny program, but I think with outsized impact given our work in policy. And I'll talk about that because last year we passed a law that actually sustainably funds more programmatic work. But how do we do this? Well, Molly is the perfect person to come right before me because like literally everything Molly said, I agree with. Social math, I was so excited when she mentioned that. Op-eds, all that stuff. Because I think the really important thing in a state where the program was literally one person for so long is how do you frame your message to gain more people to kind of sing that same song, as Molly had said, right? So what we say, simple messaging. So these are three really simple messages that we say so that when we talk about this in the health department, it's also echoed in community and in our policymakers. And I'll go over kind of how these were developed. But the first message is we save lives. So in our work with viral hepatitis, we know that there's higher rates of hepatitis B mortality in Hawaii, especially compared to the continental US, and it especially affects people who are Asian Pacific Islanders or API. We know that people, according to local data as well, die earlier if they have hepatitis C in Hawaii, up to about, I think, 17 years earlier, right? A high proportion of them will also die before they even reach retirement age. So we can kind of frame this as an economic issue as well, or a workforce development issue, right? Which brings us to the second simple message is we save money, right? So we mentioned already people are dying before they get to even retire. Our workforce is dying earlier due to viral hepatitis. So how can we address this important issue for Hawaii? We also did an economic impact report and modeling, and Jeff, you had mentioned this in your talk, so I was happy to hear that. But really, we save money and we save lives, right? So we're not saying it's one or the other, but really, if we invest $1 in hepatitis B work, the model shows that we'll gain $1.20 back. And you can see here, actually, Molly, We also love 3 hit points. So this is just a one-pager summary of a very long technical report because we don't want people to have to read that much, right? So you can see the 3 highlights there. This is what we hand out to our policymakers. Finally, we're going to save lives. We can do this. We can save money. And also we have a plan. So we're not just saying that, I hope we can do something. We actually have strategies in place that we've developed with our community members. So this is just a view really quickly of what we did with our local community members to develop a statewide strategy that was informed by our community. And it's called HEP-free 2030. Here's the mission and vision, which I'll read to you. Just kidding, I'm not going to do that to you. This is the values and practice. I think this is the emotional part of it because, in a way, this is what we all reiterate every time we talk about our work in hepatitis. We talk about reducing harm. We frame hepatitis as a social justice issue, which means that we look at this intersectionally, right? So when we do hepatitis work, we're also doing housing work, we're doing decarceration work, we're doing anti-racism work, we're doing immigrant, migrant healthcare work, we're doing LGBTQI work, right? So we really are framing it as part of a broader ecosystem of health issues. And of course, we do this with Aloha, acknowledging the culture and the people with whom we work in our state. Here's a quote from one of our members, kind of explicating that. This is the wheel of priorities that our folks have come up with, and I say this only just to kind of note that you could see access to services, that orangish color, if you can see color, is all the clinical stuff, right? It's only 1/5 of what our community thinks we need to eliminate hepatitis. And you can see one of the other quadrants is advocacy at all levels. So policy and advocacy is equally as important as access to clinical services. So what did we do to enact a law to sustain viral hepatitis funding? So back in 2021, we're like, wouldn't it be cool if we just educated our legislators on viral hepatitis? We had HCR 15 or House Concurrent Resolution pass, and then which stated that there should be a legislative briefing with health chairs, right? In 2021, that briefing was canceled. In 2022, it was not scheduled. So we're like, let's try again. And you can see here, there's all these different levels and different areas of work that we're doing, both within the health department, with Hep-Free Hawaii, which is the second one, and in the legislature. So I noted, if you kind of start at the very beginning with DOH, a Hep B mortality report came out in January. If you go down, that's when we started to do our messaging around We Save Lives with the coalition, right? So now we have data to back that up. We did another concurrent resolution with the legislature in May, and then there was a briefing that we're all involved with the legislature and health chairs in October. Out of that, they asked a question, and this is a hot tip. They're like, well, how much money would you want? I had no idea. I was like, I should have prepared ahead of time. So I was like, maybe $500,000, sure. So they asked us like, this is so doable. Now that we know the issue, please send us a budget request. And so we can kind of start to move forward, right? So the Department of Health drafted a budget request for $500,000, and we gave it to the legislature in 2023. In 2024, we spent that entire year with the Department of Health and Hep-Free Hawaii to draft a more formal budget, draft a bill, put it part of the governor's package. So by the end of the year, there was a bill ready to start in the 2025 legislature. Meanwhile, Hep-Free Hawaii, our coalition, was doing all that calm stuff that Molly was talking about. So we had a Hep C mortality report, which then one of our local providers made an op-ed about saying, people are dying from hepatitis C. We need funding for this, right? Singing the same song. And then we also had that Hep B economic report that came out at the end of the year that showed cost savings over time, right? In the meantime, we also invited our legislators to our annual meeting so they can kind of see how many different constituents were involved and also start to kind of hear the songs that we would start to sing a lot in 2025. So last year, we did a lot of work. We did a lot of that groundwork of building a narrative. And that's where you could see the Department of Health did our internal work to draft and submit testimony to establish 3 new positions and fund community programs, all for $500,000 annually. Meanwhile, all the things that we did in 2024 bore out with messaging with our Hep-Free Hawaii coalition. So now we could say, in addition to We Save Lives, we have the report that says we can save money and that we have the tools to do so. Luckily, in this 2025, Kaiser also put out a report showing that Kaiser Hawaii, they had cured their 1,000th Hep C patient. So we're leveraging all these kind of media opportunities to really show that we have the tools in Hawaii to do this. And of course, our Hep Free Hawaii Coalition were the advocates on the outside of Department of Health, promoting legislative action, sending action alerts like draft testimonies and templates for folks to kind of respond. The legislature used all this, right? Because now that we have champions to pass things through committee. And at the very end, the health chair for the House noted that how surprised he was that so many people were interested in hepatitis because there's so much testimony and media around it. So it really showed in a very kind of anecdotal way that the efforts that were made did influence and move forward this bill, which became Act 114 last year. Jeff mentioned this, and I'm so glad you mentioned this because once you pass a law, that's literally not even, you're not done at all, right? That's like maybe half the work. The other half is implementing and evaluating. So now we are living in this world, 2026, where we're actually drafting those positions so we can spend the funds that they're giving us and funding the program so we can actually show there is some impact, that their investment in this small program was worthwhile. So I'm going to stop there. I know we have about a few minutes left, so I'll turn it back to our moderators for questions. Thanks.